This is tremendously exciting to see the turnout, to see the level of interest in what was initially treated with great skepticism. And so it is certainly good to know that there is this much innovation out there, this much activity, and this much collaboration. I would like, if I could, for just a moment, to acknowledge my team that has been so instrumental in getting the NPRM out. And I want to acknowledge Ann Bollinger, who, as you may remember, ran the administrative side of the advisory board, has been an essential member of our reg team. And in the last 2 weeks while we were doing this and pulling all-nighters and everything else, she has also been completing her master's thesis, which she must defend this week. So she's had very little on her plate. Megan Elrington, who is the head of our reg team, who has done a fabulous job, and as Richard Popper said, there are more versions of this reg in our inboxes than there are adaptations to the Beatles yesterday. So Alex Pereira, who has come in and really done a terrific job in the reg team. Beth Hadley, who is helping us with our funding opportunity announcement, and Mary Ninus, who has been holding up a lot of the administrative functions. So they have worked day and night with passion and adaptability and endurance. So having said that, I just want to say that, you know, the co-op concept is really a vision at a number of different levels. One is that we really look to you to encompass the goals of healthcare reform, which are, you know, accountability to the consumer, engagement with the consumer, better affordability, and improved care. It's also a model of collaboration with each other. And I really want to emphasize that. There's a great deal that you can learn from each other. There's a great deal that you all can teach us. And also the collaboration that we hope that you will have with providers and with patients. Because what the co-op model envisions is that as you get consumers engaged with their health care, just as you get them engaged with their health care in managing chronic disease, if you get them engaged with the way health care is delivered and financed, that we can get much more consumer buy-in and involvement in the way that the delivery system needs to move. And so these are all very critical elements of what you're doing. I think in terms of sort of the things that you need to look at immediately to do is you need to, as has been emphasized, you need to have a feasibility study. And you need to do that pretty quickly. You need to have a detailed business plan that is going to be the credible model for the way you're going to run your business. I mean, it's not a theoretical exercise. You really need to know exactly how you're going to draw down money, how you're going to use money, what it's going to be used for, how you're going to build your co-op over time. This business plan has to be to you what the blueprint is to an architect. And you all are the architects. So this business plan has to show the house that you're going to build. And it has to be something that you're going to be able to follow, and that your contractors and your bricklayers and everybody else is going to be able to follow, and that we're going to be able to follow. I would like to talk just, and then I'll go walk through a little bit of the reg, because I know that's what you really care about. I just want to say that I want to address the issues that Alan and Terry both raised about the surge in the front-end demand, and just point out that that is a challenge that will be faced by all plans, new plans, old plans, long-enduring plans. As new enrollment comes in, there will be initially pent-up demand, and we expect, you know, that to be a curve, right? That as we get a system that has more and more people in it continuously and consistently, that sort of pent-up demand will go down over time. So what is that? So what does being able to manage that mean? It means, first of all, that you have to have adaptable IT systems that are flexible and nimble and can enable you to follow this demand and figure out how to deal with it. It also means that you need to have in place good chronic disease management approaches. and management approaches, even for people that don't have chronic disease but may have sort of pent-up acute needs. How are you going to manage those patients? What is the delivery system that you're putting in place to make sure that they are handled efficiently, responsibly, in ways that are consistent with the highest quality of care? And that is really, that needs to be the goal. And that is also, coincidentally, the most efficient way to contain costs in the long term. I think that, if you were at the advisory board meetings, and I know most of you were, the existing cooperatives were very generous in their offers of providing technical assistance. And I would just encourage you to take them up on those offers. If you want to go to our website and then look down to the advisory board proceedings, you can get the names and the information on the experts that testified from those plans. I would encourage you to engage with them. Let me talk a little bit now about, as Steve mentioned, the funding opportunity announcement, which we in the government addictively refer to as the FOA, will be coming out, we hope, by the end of the week. And that will really contain most of the details of what you need to do. That is, for lack of a better word, that is our request for proposals. The funding opportunity announcement is the request for proposals. That is what details what you need to provide us in order to receive funding. It will set out the timetables. It will set out all of the critical information. In terms of walking you through the reg, at least superficially and in summary fashion, it does provide for two types of loans, startup development loans and solvency loans. Eligible people are, as it tracks the statute and the advisory board very closely, eligible parties are issuers who were not in existence prior to July 16, 2009. The people that are nonprofit, non-issuer organizations that may have sponsored small health insurance plans are eligible to participate, provided, and this is again, they have to be a nonprofit, non-issuer, provided that the co-op that they set up is a completely separate organization, that it meets all of the co-op requirements. They have to set up a nonprofit, not-for-profit, public service organization that is member-run. And they can do that in parallel to whatever their existing things are. So if it's a religious organization, if you are a union, if you are a community service organization, whatever you are, if you were not an issuer, you can set up a co-op. The key here for all of these organizations is, again, to remember what the basic qualifications are. You must be a nonprofit, not-for-profit public service organization. You must be organized as appropriate under state law. You have to be on the road to being licensed by the state. You can operate in multiple states, but you must be licensed by every state in which you operate. Now, the other thing in terms of these requirements and the sort of collaboration issues that I was talking about earlier is that you might want to think about, and I don't know whether it's appropriate, one of the things this reg does not do and one of the things the FOA does not do is tell you how to run a co-op. We do not tell you how to run the business of insurance. Okay, we are looking for you to tell us how you intend to run the business of insurance. Okay, but you might want to think about, look around, see if it's appropriate to combine resources and mission and maybe join together with other fledgling entities to form a single co-op. Think about what are the greatest ways that you can get your efficiencies. So there are lots of options here, especially since you can't operate in more than one state. And I know that Jerry's group has been thinking long and hard about how to do that. These are obviously loans. An interest rate will be determined. It is not in this reg. For startup loans, they are repayable in 5 years. For solvency loans, they are repayable in 15 years. The proposed rule does indicate that the repayment on the solvency loans should take into consideration the solvency requirements of the state and be structured so that state insurance regulators will accept them as reserves and not debt. So there is a tremendous amount of flexibility here to make sure that these solvency loans are recognized for the purpose for which they were intended. I'm trying to think of other key elements that, in terms of the governance requirements, 51% of the boards must be consumers, members of the plan. Every member of the plan must vote for each director. So in other words, you can't have directors that aren't elected, okay? But all of the directors do not have to be members of the plan. So in other words, you could have designated seats for people with specific expertise, for example, employers, bankers, finance specialists, actuaries, whomever you want to have on the board. But they have to be put up and the members have to vote for them. Okay? And it is competitive. There must be more people nominated than there are seats, so that people have they have choice. It can't just be, management slates and it's up or down or you're out. They have to be contested elections. And that's a little bit of a challenge because not everybody wants to do this. And being on the board of a co-op is even more demanding than being on your PTA. It's hard enough to get people to do that. So, these are challenges. You have to have a membership that embraces this, and it will entail educating your membership about the responsibilities of membership and teaching them what it is exactly that they're doing.